Welcome to the WSPID Podcast series. We're your hosts for this episode, Dr. Linny Phuong
and Dr. Alicia Chang. In this special episode, we are exploring how artificial intelligence is already transforming the practice of medicine and what the future might hold as AI technology develops further and becomes integrated into diagnostics and treatment.
And so to navigate this discussion, I spoke to Dr. Sriram Ramgopal, who is a researcher and attending physician in pediatric emergency medicine. So what we did in this interview was we talked through some case studies. We talked through, AI, its applicability, some of the models that have been created, and talked about those fears and misconceptions. Alicia, I know that you had some hesitation about what AI actually meant and the applicability. What were you hoping to get out of this?
Yes, I have to confess, Linny, that for me AI is still very unknown, and even though I have started to see how it is being used in a lot of fields, even when we are scrolling through some of the journals, they already have their AI segment, and I think it's gonna change a lot of things that we do right now. It is important to learn about it. Also, do not be scared about it, because I find a lot of my colleagues worried about artificial intelligence replacing us as doctors, which I don't think is ever going to happen, but it's going to be an important tool for us to get to know and get to use. If I'm correct, I hope I'm correct.
Yeah, I love that. I think that's exactly what this discussion will go into. Certainly, we hoped to address some of the fears and misconceptions. So I think one of the main things from this episode is that Dr. Ramgopal, our guest, talked about how AI is a very sort of broad term and that it can incorporate lots of different elements, and that he was really fantastic at breaking this down.
Let's hear your conversation with Dr. Ramgopal.
Welcome to the Syndromic Insights podcast. Dr. Ramgopal, we're so privileged to have you here with us today.
Thanks so much for having me.
To give our audience a background about you, I'm just going to read a little bit about your bio. Dr. Sriram Ramgopal is an attending physician in emergency medicine at the Anne and Robert H. Lurie Children's Hospital of Chicago. He's also an assistant professor of pediatrics at the Northwestern University Feinberg School of Medicine. Dr. Ramgopal was educated at Sri Ramachandra University in Chennai, India, and undertook his postgraduate fellowship in pediatric emergency medicine at Children's Hospital of Pittsburgh, as well as a residency in pediatrics at the same hospital. His clinical interests are trauma, emergency medicine services, and sepsis, and we also understand that he's an avid learner of AI. So to begin with, Ram, could you please tell us what we mean by AI or artificial intelligence in the context of healthcare?
Absolutely. This, I think, is an interesting topic, and it's always a nebulous term. I think artificial intelligence can mean many things to many different people. The definition has some flexibility kind of baked into it. From a healthcare perspective, I think it's appropriate to consider AI as a field that focuses on how computers can learn from data and the development of algorithms that make this learning possible. So if you think about that, a number of common technologies or exciting, innovative technologies use AI in different ways, things like language processing, planning the best course of action, and AI is also used in applications like robotics and motion.
Yeah, okay. I'm going to touch on a few of those things later on. Before we get into sort of some of that detail, can you tell us a little bit about how you became interested in integrating AI into the field of emergency pediatric care?
Yeah, absolutely. As you mentioned, I did my fellowship in pediatric emergency medicine at the Children's Hospital of Pittsburgh, and it's around this time that I started to get really interested in these concepts of quote-unquote big data, which itself is kind of a slippery term. And I got more interested in data science and how to manipulate data sets to glean information that could be clinically relevant. As a clinician who kind of developed a secondary interest, I felt like I was able to approach things from a more clinical context. I was able to ask questions that I thought were potentially more relevant in the care of children in the acute care setting. That naturally kind of segued to this interest in artificial intelligence, because artificial intelligence is really kind of an expansion of statistical practices that have become more and more possible with the development of greater and greater processing power. So it's really just this, taking statistics to the next level and kind of leveraging the computational power you get from this next generation world that we live in. And specifically with respect to pediatric emergency medicine, I think it's very interesting. As you know from your specialty, so much of pediatrics, I think, is finding that needle in the haystack. All the kids that I see in the emergency department, I was just there last night, they're all fine, except for the one or two that are definitely not fine. And trying to figure out those one or two kids from the sea of children that have relatively minor infections can be quite challenging. So whatever tools that we can leverage at the bedside to potentially enhance those predictions that we make and say, this child is worrisome, these children I'm not so worried about, I think has a lot of benefit. And so AI is just one more technique that might be useful to have in our toolkit to identify those potentially sick children or those who might have a clinically important problem or infection.
Yeah, I love that reference to the needle in the haystack. Ram, can you tell us at your hospital, so at Lurie Children's, how is AI currently being utilized?
Yeah, so it's important, I guess, to remember what's included in the definition of AI. So, things that we sometimes call statistics, if you ask the right person, would also be considered as a type of artificial intelligence. So things like regression, which really kind of you think about as falling in the category of statistics, like logistic regression we see very commonly used in research literature, is technically a type of AI, even though you could consider it to be a kind of rudimentary or kind of maybe basic form of AI. But it's nevertheless, it fits this definition of computers trying to identify patterns given existing data. And so logistic regression, I think we use fairly commonly in the emergency department, and you can build it into prediction models. And so when you think about a paper that you have read and you're trying to identify septic arthritis and you recall the Coker criteria, that technically might meet the definition of AI. It's not, maybe what people have foremost in their minds. In our institution, I think it's similar to a lot of other places where AI is still relatively novel and cutting edge, and using these more advanced algorithms to drive predictions remains somewhat limited in my hospital. We do have a system that I personally don't use, but which is available, which we use to identify patients who are admitted to the hospital, to identify which patients have the highest risk of returning for like a repeat admission within 30 days. And so that was recently published. And so that algorithm is used by our inpatient folks to identify patients who have a high risk of those return admissions. So that's probably the most advanced case we have of AI in our institution. But I think there's like you mentioned, there's so much interest in new ways to apply this technology.
Yeah, no, that's fantastic. Thank you for that sort of overview. What we might do now is let's jump into a case scenario, because I'd love to see sort of the applicability. So the first case is a 3-month-old infant who presents to the emergency department with a fever and essentially a urinary tract infection is suspected. How is AI being used to assist in the diagnosis and management of these febrile children with suspected UTIs? And are there any particular sort of decision support tools or algorithms that I guess are being utilized at the moment or have been proven to be effective?
Yeah, absolutely. So we have long known that children who present with a fever can be at risk of urinary tract infections, and there has been a great body of literature dating back to at least the last 30 years that have identified possible risk factors, because we don't want to obtain a urine specimen from every child with a fever in the emergency department. It's an invasive procedure, it's expensive, and it's resource intensive. It takes a nurse's time and skill to acquire that sample. So clearly, we don't want to be doing that test on everybody. That would have a very high sensitivity, but extremely low specificity. So people have long since tried to say, okay, which are the kids that we really need to think about getting urine testing for? Perhaps girls, perhaps uncircumcised boys. Does age factor into this? Does a younger age lead to a higher risk of UTI compared to an older age? Does a past history of UTIs factor into this? What if the child looks like they have an ear infection? Does that modify the risk of having a urinary tract infection? If I see a child with an ear infection, sometimes I stop there. I don't need to get urine testing. I'm satisfied. I can give antibiotics and treat that condition. This goes back for a while, and people have been thinking about how do we judiciously use diagnostic testing to minimize harm to patients and optimize use of resources. And so again, thinking about AI as including those techniques like regression, there has been a lot of exciting developments in using regression-based techniques to predict patients with urinary tract infections. One amazing work that was done over the last decade was this development of the UTI calc prediction algorithm. And for this, investigators in Pittsburgh identified children who were being tested for urinary tract infections and constructed this logistic regression model to identify patients who might have a UTI based on those risk factors that I just mentioned, as well as some others. In the regression model, you generate coefficients and an intercept term, and you're able to basically, if you have a new patient, you can plug in the information that you know about the new patient. For example, did they have a past UTI? Is there another focus of infection? Are they a girl? Plug those into the coefficients, and then you can generate a new predicted probability, and then you'll know that the probability of having a UTI in this specific patient in front of me is 5% or something like that. And you can use that information to help you decide if you want to pursue urine testing, or if you want to talk to the family and do some shared decision making, or if you're just not at all concerned and you can say, I don't think that's what's going on. Let's look for some other cause of your fever. And so those folks who constructed that UTI calc system also constructed a website. So that would be a great example of clinical decision support that uses a regression-based technique. That is, in my institution, we use it a lot. Our residents are almost practically trained on it, and they consider that anytime they're seeing a young child for whom they're considering a UTI. So that's a simple example, but nevertheless, an important example of how an AI technique might be deployed in clinical practice.
Yeah, and so sort of looking towards the future then, Ram, how do you envision AI sort of changing the way that emergency departments operate in in say the next decade?
Absolutely. So, I think I keep bringing up this idea of regression, and the reason why I like regression, I've spent a lot of time playing with these more fancy algorithms, but regression will always have a special place in everybody's heart because it's so easy to interpret. It makes sense. Yes, a girl, you should have a higher risk of a UTI. It makes sense if there's an ear infection, I should be less concerned for UTI. So it fits with human reasoning, whereas a lot of AI techniques maybe don't have that advantage, and they can be a little bit more opaque with how they generate their predictions. A lot of algorithms will just say the probability of UTI is this, and there's no rationale that drives that decision. Nevertheless, things like UTI calc are amazing. What I think people would like to see moving forward is AI techniques that are more built within their existing electronic health record system. So you could potentially imagine a world where, and it's probably not that far off, and I know that there's some interesting research that's been published about this, where if a child presents to the emergency department with a fever, their first interaction with the healthcare setting in this context is there is a triage nurse who collects some information, collects vital signs, collects some information about chief complaint, maybe a sentence about what's going on. That gets charted into an EHR system. And so from that second, data starts to get collected about that patient. You have a set of vitals, and you have maybe one or two sentences about what's going on. Can you start to use that information that starts at that time zero and that progressively gets built on as the patient spends more time in the healthcare system to generate live predictions of multiple conditions and not just UTI? If there are certain risk thresholds that are exceeded, that could potentially prompt the clinician through some sort of decision support or other system to perhaps get this testing. I don't think that world is far off. And I think there's a lot of potential here. There's a lot of great work with the sepsis prediction, particularly among patients that are admitted, and particularly among adults, where that literature perhaps is most robust, where you can build in AI algorithms that work behind the scenes of the EHR that are looking at the data that's being put in by nurses, clinicians, looking at both structured data, like things like vital signs that are just a number or a lab value, as well as unstructured data, like perhaps physician notes or consultant notes or nursing notes, putting that all together and coming up with live predictions. And when perhaps a patient appears to be teetering on that point of becoming unstable, alerting the clinician saying, hey, this patient might have sepsis. Why don't you do something about it now? And perhaps you can intervene at a point before they get too sick. So in the ED, of course, it's more challenging because there's less data available, but I think that application is around the corner in the place where I work too. So that way, the resident or the clinician is not thinking, oh, I should think about UTI. Let's load up uticalc.com and look at this risk of pneumonia. Of UTI by plugging in these these variables. They can get those predictions on the fly, as they become relevant.
That sounds pretty incredible. So Ram, what we're going to do now is we're going to shift to thinking about older children. And I guess let's go to our second example. So in this case study, we've got a 15-year-old patient who potentially has a community-acquired pneumonia. I guess with this particular child, are there any challenges or opportunities that present, that are different with managing a respiratory infection, and also are there any differences in terms of adolescents compared to younger children, and how that works in the sort of, I guess, AI world?
Sure. So pneumonia is an area that I have specific interest in, and I think is a very relevant one because pneumonia it accounts for a pretty significant degree of morbidity, both in the developed and developing world. It's a common infection, and yet it's an extremely slippery one to diagnose. We know that certain clinical characteristics are associated with pneumonia, but it's one of those conditions where coming up with that clear discrimination between this patient has pneumonia and this one does not is really hard to do. You think about pneumonia more in a patient that has increased work or breathing, or that has perhaps hypoxemia when you obtain your pulse oximetry. There's been some research that supports that there are some things that increase the likelihood of pneumonia when they're considered in isolation. But we also know that there's no single examination finding or sign that's going to say this patient likely has pneumonia and this patient does not. That brings this idea to mind of, can we look at multiple risk factors together working in tandem to potentially identify patterns in disease presentation that otherwise vex us because there's a lack of a clear sole discriminating feature for the presence of pneumonia. So can we combine multiple features together and then use that to generate a risk of prediction for pneumonia? And I think it's possible. I have done some work with my mentor, Dr. Todd Florin, looking at single center data to identify risk models for pneumonia. And we know that variables such as older age, increasing duration of fever, perhaps breath sounds, like decreased breath sounds, are associated with the presence of pneumonia, whereas other things like the presence of rhinorrhea or wheeze are negatively associated with pneumonia. And so the performance of these models, I think, have an area under the receiver operator characteristic curve of like 0.75, 0.8. So there's some potential here to use these types of models to identify patients with pneumonia. If you're considering using kind of higher end AI algorithms, there might be opportunity to further improve upon those predictions. Pneumonia, as you mentioned with age, the differentials that compete with pneumonia are heavily influenced by age. So in the younger age group, pneumonia and bronchiolitis intermingle a lot. And most of what we see in younger children is really just bronchiolitis. And so trying to figure out the kid with pneumonia from the hundreds of toddlers with bronchiolitis can be quite challenging. And so the way an AI application would consider age in that younger age group might be different from how it considers age in an older patient, where the differentials might include conditions such as asthma or quote unquote atypical pneumonias or like walking pneumonias. And so how do you identify pneumonia in that population is quite different. And so an algorithm would ideally be able to consider both of those populations and identify distinct subpatterns in those age groups.
Yeah. And so, Ram, what was really interesting in that is that, you sort of talked about how AI would sort of calculate based on algorithms and the factors that you would enter into the model. you very much continued to go back to that clinical examination. And so I guess, the whatever the AI spits out in terms of an answer and their questions, and it really depends on what you put in. So going back to that clinical exam, um, I guess my question is, do you think that AI will ever sort of take over our jobs as doctors in healthcare? It's kind of
That's
obviously a loaded question there.
It's a very loaded question. Um, and the short answer is I clearly I don't know. There are certain parts of our jobs that I think are very prone to being routine and mundane, such as things like documentation. I think there's going to be a clear role for AI to assist in those sorts of tasks to streamline that process, hopefully make it easier, hopefully lead to the generation of notes that don't just have a lot of noise, but actually have important information, and that's easier to understand. So there are certain aspects that I think are very obvious. With respect to making clinical decisions, I think there's still in pediatrics, in our specialty of pediatrics, I think there's still a strong role for the human physician, to kind of synthesize information, take the physical examination that we get, take the information that we get, consider the context of that patient, both with respect to their medical needs and in many cases their social needs, put those together to come up with a plan that makes sense. And sometimes what a prediction model can tell you, even if it has perhaps greater accuracy in some situations, may not be applicable to the patient in front of you for whatever situation. So I think, for my lifetime, I don't see AI replacing jobs, but perhaps augmenting them, improving the ability to make predictions, perhaps facilitating some of the routine tasks that we do to make it more easy. But who can say what will happen after my lifetime? We're talking next 100, 200 years, things might change even more.
Yeah, no, that's great answer. And I think I love the part where you talked about us as human physicians, as opposed to, I guess, the alternative, perhaps.
Right.
I guess I think the other thing that sort of that we always think about with AI and potentially being replaced is that sort of human factor. And I would have thought that having that sort of human connection cannot be replaced, and therefore, we hopefully will always sort of have a role within healthcare and managing patients.
I think so too.
So Ram, a few terms that kind of come to mind when we talk about AI, natural language processing. Can you explain a little bit about what this means and how this applies to health and healthcare?
Sure. So natural language processing is um, describes a term of how computer algorithms can process free text information. And so NLP, as it's usually abbreviated as, has been around for some time, 20 to 30 years, and it's been progressively advancing. You can certainly think of even things like keyword-based searches to be early examples of NLP. And of course, in the last 1.5 years, the innovation of large language models has really changed the scene and kind of upended it entirely. So these large language models, or LLMs, of which ChatGPT is by far the most famous at this time, started to appear on the scene about 5 years ago. They weren't very good, and they were not publicly available. But anybody who's played with them for a few minutes today can see that they're very useful for a variety of things. Writing emails, making presentations, answering clinical questions. They perform fairly well in that domain as well. It's important to know that LLMs don't quote unquote know anything. All they're doing is they're breaking down the text input that you provide it. They're converting it to base units called tokens, and then they're trying to predict the next token that should come next in the sequence. So literally, it's and if you think about a token as a word, which is like a rough approximation, it's really just trying to guess the next word in a sequence. And usually that the answer that it has put together kind of fits well, and we like it, and so it has some utility. There's so much excitement about how large language models can potentially change healthcare. They have a role in things like medical education, we know that large language models perform reasonably well on board review type questions, or if you ask it a clinical question, it can usually provide clinically relevant information. Again, it doesn't know what it's telling you, so sometimes it's prone to errors, and you have to still be careful with that. People have looked at LLMs with respect to patient education, things like discharge instructions. We find that discharge instructions are still not simple enough for most patients to understand in terms of reading level. And so large language models can help to further simplify complex instructions into bite-sized layperson language that can be really helpful. There's a lot of great interest in AI-based documentation, microphones that just listen on the conversation with the patient and then synthesize that into a completed clinical note that you just have to review and not have to start from scratch with. I do a lot of data science-based coding, as I alluded to, and I use it as a coding friend pretty frequently. If I get stuck in a specific type of analysis or I need ideas, I will frequently query a large language model to get ideas about like how to code a specific question. And for very simple questions, you can even upload data into a large language model and it can do the analysis for you. My experience with this has been limited, and I would be cautious if I was planning on publishing something like this. And of course, there's concerns about uploading private health information into a publicly available system, which for sure you should not do. But in certain situations with de-identified data, there might be a role for this here. So there's lots of exciting ways in which NLP and specifically large language models can really be applied, both to healthcare and research and other applications.
Yeah, wow, that's really impressive. Thank you for sharing that. And so you sort of alluded to some of those things in terms of considerations. Are there any other sort of key considerations that you would, I guess, have us consider for integrating AI into pediatric care pathways and I guess that future use of AI?
Absolutely. So there's so much excitement about AI, and I think people are tripping over themselves to come up with the greatest and coolest algorithm for X disease of interest that they might have. But I think a thoughtful approach is critical. This goes back to research 101 or statistics 101, which is if you put garbage into your model, you're going to get garbage out. So thinking about this in a proactive manner is critical. There have been some fantastic summaries of how AI-based model development should be pursued. And really, you should always have an eye towards implementation, even from day one. Thinking about who is going to benefit from your model, how is it going to be used in practice, and does it matter? Is it going to change what we do for the better, or is it just going to introduce more complexity to an already complex healthcare system that we exist in? So it's essential, if you're thinking about, hey, I would like to construct a model to improve the prediction of pneumonia, that we talk to stakeholders, talk to your experts from infectious disease, talk to clinicians who will be using a support system that you plan to develop, talk to potentially parents and caregivers who might care for a child who has frequent admissions for pneumonia, maybe a child with some degree of medical complexity, people that would be subject to the model. Look at the existing evidence that's already out there, develop a model in that light. AI-based models, in my experience, are very finicky, and they are more prone to overfitting than a lot of logistic regression-based models. And by overfitting, I mean you have trained a model that predicts information within your data set, but it may not predict information in other places, in other data sets, in other periods of time. And so external validation is perhaps even more important in AI-driven models compared to kind of more conventional statistical models. A lot of model development with AI is done using retrospective data, and we know that because we are humans, we are imperfect beings, and so if there's any type of subconscious bias that drives our behavior as clinicians, that's going to get picked up by the model unintentionally. So even if you actually don't code for variables like race, if you don't tell your model the race of the patients, but you systemically treat patients in a different way because of their race, perhaps driven by subconscious bias, that those types of biases can become perpetuated in an AI-based model. The model does not know what it's doing, but it will give predictions that may be prone to the same biases as the data that was used to train it. So once you construct your model and validate it, it's important to explicitly then evaluate it to see how it performs on potentially vulnerable subgroups, perhaps by race, minority status, or socioeconomic status. So kind of look at its performance in those high-risk groups. Once you have developed your model, you have to actually implement it. Typically, I would recommend single center implementation. How does it work in my hospital, in my setting? Look at its uptake. Are my colleagues using it? Are they finding it useful, or do they just find it like one more thing to click through that's driving them already crazy? Look at potential balancing measures, right? Every model has a balance between sensitivity and specificity. Are you potentially missing cases of a disease of interest, which might be really bad? Typically in pediatrics and in medicine in general, we prize sensitivity. We don't want to miss anybody who has a condition, and we would rather capture a bunch of people who don't have a condition to not miss anybody who does have it. So you want to make sure that you're not losing sensitivity. And similarly, if you're not improving your specificity, are you now getting more testing that's unnecessary in kids that don't need it and then causing harm in that way? So look at balancing measures on both sides with false positives and false negatives. And then, of course, you should look at the model performance. And then if it seems like things are going well, then you can focus on dissemination, commercial dissemination, academic dissemination, building it more into your EHR. As the model migrates from health system to health system, its performance will vary different. Well, it'll vary compared to how it performed in your site. And so some models will require some degree of recalibration as well.
Yeah, that makes sense. You've explained it in a really accessible way. Thank you. Are there any other ethical considerations that you think that we should sort of consider with AI?
I think I talked about the biggest one that's on most people's minds, which is potentially worsening bias and exacerbating inequities in care. I think that's a really important one that can't be understated. People used to, by used to, I mean like 5 years ago, include variables like race explicitly within prediction models. The most probably well-known example in pediatrics goes back to urinary tract infection, where African American race was found in several studies to be associated with a lower risk of urinary tract infection. It's unclear if there's any real genetic predisposition towards having a low risk of UTI, or more likely if this is just reflective of clinician testing patterns from the periods when those studies were first performed. And so, this is, again, a nice example just because it's logistic regression, so it's easy to think through. But if a model has learned that African-American race is associated with a lower risk of urinary tract infection, then one could potentially imagine that you are getting less urine testing on kids who are of Black race that are presenting to the emergency department with a fever, missing more UTIs in that population. And so that same tendency that we saw there can exist in many other domains, and that can even exist, we have found, even when you do not explicitly include race as a variable for your model to learn from. So it's essential to think about this when you're training your model, giving it clean data, and then when you're evaluating the model, looking at those subgroups with care to make sure that you're not causing any harm. With respect to large language models, there have been additional ethical considerations. If you're a researcher who's interested in using LLMs, there's a lot of concerns about potential authorship issues. There are some kind of glaring publications where people clearly used AI-based models to write part of their paper for them, and it looks not so good in hindsight.
Okay.
The ICJME, that's the International Committee of Medical Ethics, has published specific authorship guidelines, and they have made it clear that large language models cannot meet authorship criteria because they cannot take responsibility for the work. And so, how are these deployed in a way that that doesn't just generate more garbage with respect to research, and that leads to well thought through, methodologically rigorous research is another important consideration too.
Yeah. It's funny, when I asked you about ethical considerations, the first thing that I thought of was actually patient privacy and sort of that data security piece. Is that something that we should be worried about?
Mm-hmm. I think that's really important. I think that the risks are similar to the risks that we currently live in, with pretty much all patient data being housed on electronic platforms. And so there's always the risk of privacy being intruded upon through things like hacking. And when you're talking about an AI-based model, the AI requires data to run, and so where is the model being housed? Is it being housed locally within the servers of your institution so the data doesn't leave anywhere, or is it being housed at another repository where data has to actually leave your institution for the model to run, for it to feed information back to your system? And so patient privacy, I think, is an important concern there as well.
Yeah. And so finally, what do you think is the next breakthrough in AI for pediatric medicine, or for, I guess, applicability to medicine?
Yeah, absolutely. I'm one person, and I'm always amazed about what gets published, and I would never have thought of that. So I think it's hard for me to make this call. I think, as I've mentioned, people are falling over themselves to construct AI models, but really not a whole lot has been done with respect to implementation. And so I think that's where the next big thing will happen in our world of clinical medicine is going to be AI models that are constructed, that are baked into the EHR, that could potentially drive clinical care from behind the scenes, instead of you having to proactively go out and look for it. It's being done for you, which I think has a lot of potential to improve the care that we deliver. So I think that's for me, that's what I'm most looking forward to.
Okay, fantastic. And where do you think your work is going to go and sort of lead in the coming years?
Yeah, sure. So as I maybe suggested earlier, one of those areas that I'm really interested is in LRTI and pneumonia prediction. And so I've been working with a number of analysts at my hospital to see if we can generate EHR-based predictions of pneumonia among children that present to the emergency department. And so that's specifically one area that I consider that I'm going to be spending more and more time in the years to come.
Fantastic. Thank you. Thank you so much for spending some time with us and sharing your expertise and insights with us today. I'm certainly looking forward to seeing how AI continues to evolve and, I guess, impact pediatric emergency care. Thank you.
Thank you so much. This has been a lot of fun.
So after listening to this episode, I understand that AI is going to be a tool that, is a tool that we're going to be using more and more, and that we need to integrate it to make our daily work easier. But still, you need to have the ability to integrate all of that information and then translate it to the patient and their families in a very careful and thoughtful manner.
No, I agree, Alicia. I think what Ram talked about was that AI is a good enhancement to our clinical skills and knowledge, and that some settings are already using it, and those who are embracing it and trying to work around how it is best utilized in day-to-day practice. And for those settings where we're still learning about it and it's slowly coming into practice, it'll be about how to make sure that it enhances what we do and supplements what we do rather than replaces. So I think for me, it was a very reassuring conversation. I think like you, I certainly was a little bit afraid and perhaps didn't realize that AI is kind of already happening in the background, and perhaps I'd overlooked it.
For more information on the role of artificial intelligence in clinical pediatrics, visit the Global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insight.
And that's the end of today's episode. We wanted to say a big thank you to Dr. Ramgopal for his insights into artificial intelligence and how it can enhance diagnostics. Perhaps the future is not so scary after all. We hope you have enjoyed these conversations as much as we have. Please share the podcast with your colleagues and leave us a review and rating. Take care.